So it's a pleasure for me to be here and sharing with you, finishing this wonderful session on future technologies and already device, what is upcoming on imaging perspective. What I'm talking about is, it's about an idea of having all the stroke imaging integrated in one single room. And there is a background behind it, and we will start talking about it first. So those are my disclosures. And today, if we look to the workflow of acute stroke, we have different steps: detection, transfer to a stroke center, medical evaluation, imaging, acute treatment, and the postoperative care. But the focus on the treatment, I mean, a lot can be decided and can be changed, and it's all on the imaging and on the acute treatment. The previous and the post-management depends on the cities, on the centers, on the different systems. And since 2005, with the randomized controlled trials bringing endovascular treatment to the light of the evidence, we have now also the treatment of those large vessel occlusions, focusing on the endovascular treatment of stroke. One aspect that those trials became positive 2 years after 3 trials were negative on acute stroke, were for sure innovative devices, improvement of the techniques, but also much better times. So the workflow and the focus on workflow was something that was very important. So today, all the different devices that we have are circulating into those two approaches, a stent retriever or a large aspirating catheters. And so we are more consistent, and everybody is doing the same type of image. And despite of that, we see that on different studies, the time is still an issue. Independent of the best recognition, best device, best system, best patient, the time will play a big role. And so as much as you can save time, more than trying to bring in the best imaging quality to evaluate your patients, this will be probably the best you can do to help those patients. So I will start sharing with you a case that is quite common here for the colleagues in Toronto and in the Great Toronto area. I see that we all have calls from patients that are far away and that are transferred to us. This is a case that we evaluated recently here, a 54-year-old patient that at 7 in the morning had a stroke on set, and at 8 a.m. came to a hospital in Barrie, north of the city, and north of Toronto. It was a city north of Toronto, and they performed the CT over there. So they called the critical, and we were online, and we were called at 9:20 to review the images and talk to the colleagues there. 9:25, we had the authorization, and we accepted the patient. And so this is the Google map, and we have here 2-hour time from Barrie to Toronto. So the patient arrived at the Western at 12:10. So we can't change the time. We had to play with the transportation that we had available at that time. And I think for a weekday, they did pretty well. So coming from that north, so he arrived. So because it was more than 1.5 hours after the initial imaging, we decided to repeat. So this is the repeated CT. We see that there was a slight progression of the stroke, but since the patient had very good collaterals, we also did a perfusion, and we could still see that we had almost half of the MCA territory to save. So these are images of the procedure. We recanalized, and the patient did very well after. So if we see all the workflow from this patient, so we always looking back on what we could do better. And what I think is that if inside our hospital we could just bring the patient directly to our angio room and do everything there, we would save a lot. And we would, instead of starting a procedure 40 minutes later, I would be starting the procedure as the patient arrived inside the hospital. So we did also an evaluation on the workflow on Swift Prime. So we are always discussing, do we need, what type of imaging we need to evaluate those patients? Do we need perfusion? Do we need, So on Swift Prime, we had a very detailed timeline, and we saw that for sure a patient coming directly to a center we save a lot of time from a peripheral to a tertiary center referral. And the Swift Prime demonstrated that we have 60 minutes to treat a good patient. Beyond that, from your imaging modality, you will be sacrificing brain from those patients. And when you see from doing perfusion or not, or adding a refined perfusion image, it didn't change the clinical outcome of those patients at all. So this is why we think that we should be focusing on improving the outflows. And Swift Prime was done, was one of the randomized controlled trials done in very advanced and high volume centers, as well as other trials. Another trial that we also did, a workflow evaluation, was a trial that we did in Europe and some centers here in Canada, called STAR trial. And we evaluated the different time steps. Was a study that Mayank was responsible for it. And we saw that also 86 minutes can be saved if we try to condense and improve the workflow, focusing on the imaging evaluation inside the centers. And the last study that I would like to show and to discuss on this approach is a study that was done by Tudor in Pittsburgh, over 600 patients with intra-arterial treatment. And they evaluated directly patients coming directly to the angio room, or patients coming and performing image at the emergency department. And as you can see here, it's a significant difference between the times, and it did influence the outcome. So if you take, for example, a workflow distribution of a trial that was the EMS, if you cut the intra-facility transfers, you can get it down to almost half of the time. So now the question is, where is the best place and what is the best equipment to have everything inside? And for sure, since the treatment is centered into the endovascular approach, having all the imaging into the neuroangio switch is kind of the logical step. So this is why this approach, one-stop shop for acute stroke, is what we will talk about now. So, but are we ready for prime time? So we have the possibility to do cone beam CT into those angio machines, and cone beam CT is being largely used on dentistry, but because we have an X-ray and emission that is powerful, and we have now those flat detectors, we can now reconstruct the imaging with a pretty good parenchymal reconstitution. And we have different companies. Every company has your different technology, and they developed, and everyone has the different specificities. But just to give you an example, they've been improving the flat detector technology to also improve the expert CT image. This is one of the cone beam CTs from Philips, and they increased the layer of detection. And in fact, they can improve the quality of the image and increase the contrast. They could decrease the pixels, and they could correct a lot of the artifacts that we usually saw in those pictures. And the image that we have at the end, most of the cases, we have a 620 images in one acquisition. Most of the equipments will give 3 to 6 seconds of reconstruction time, and you will have an image that is ready for you right after. But if we are looking from a stroke perspective, what we need to know to decide to treat or not the patient. This is a list that I made, aims of imaging on stroke, detect and exclude blood if you are seeing the patient for the first time, detect ischemia, detect occlusion, detect tissue at risk, predict outcome of treatment, or follow up after treatment. So if we look, the first 4 are probably what we need to know immediately before the procedure. So detect blood, we have here 2 examples. They are two images showing one subarachnoid bleeding and one intracranial hemorrhage. It's curious that we don't have much in the literature comparing the expressity of bleeding and CT, because it's quite obvious, but I think we are there. I think we can say that expressity can be reliably used to exclude blood. Now the next question is how good we are to detect ischemia. So this is also an experiment image done with different expressities. And this is one of the latest expressities. And this is a phantom image, and I'm showing to you to show mainly the problems that we have with a cone beam CT. One is the central artifact. As you can see here, this ball that goes eccentrically. It's in almost all cone beam CTs. And also when you have a dense image that is in more than 120 degrees of the rotation, it will produce this the artifact just beside, and it makes it very difficult, for example, when you are analyzing ischemia, to look into the periphery of the parenchyma. So these are also probably images of the first generation expert CTs. And if you see some of those brain images here, I kind of say that we are not ready to detect ischemia. I wouldn't be comfortable treating a patient looking for a CT with that quality. But now, almost all the companies are improving the convolution-based scatter correction to decrease the pixel. And since the image is done in one plane, they are trying to fix this scatter projection. And this is an example of how this image has been evolved. So on the superior line, we can see an expressity back in 2006, a new technology, and some improvements on the post-processing. And here the same phantom on a CT, and we can see that in terms of contrast differentiation, they are rather similar. And also something that most of the companies have been working is to reducing those artifacts that are creating by the bone. And one of the strategies that have been using, so this is, we are still evaluating this device, is to change the angle of the acquisition to also reduce those artifacts. And we can have images like this. So this is also a phantom experiment. And as if you look to the posterior fossa here, that is sometimes impossible to see was in the past. Nowadays, with this new technology, we can kind of look with a similar and acceptable contrast brain differentiation. These are some examples of comparison of how those reconstruction softwares have been working. So this is an expert CT with a regular acquisition, and you can see here the artifacts on the periphery, and here with a correction we can kind of evaluate pretty well the brain parenchyma. This is another example to show how this is the beam shaper and the dual axis scan, and this is the expert CT, and we can see that the surface and the cortex can be widely evaluated. This is now some other applications. We can evaluate much better now the posterior circulation. This is a reconstruction of a regular expert CT, and this is with this dual axis. And as you can see, we can significantly evaluate the cerebellar tissue that was an issue in the past. So with those reduced artifacts around those bony structures, I think we are pretty close, I would say. This data for sure require validation, but I think now we can start thinking about bringing a patient to the angio room and evaluating there. At the end, it depends on what is your threshold to treat. If you say that you need an MRI and a perfusion, then we will not enter in discussion. But if you say that despite of all the beautiful imaging, you will still treat a patient if there is up to 50% of the MCA territory, I think you probably will be happy looking to this type of imaging and saving 60 minutes of your patient's time and improving your hospital workflow. So this is the status of at least the XpressCT. The DynaCT has also a lot of new protocols, and we have a very fast acquisition speed, improved of the contrast resolution, and reduction of those artifacts. So I think that to detect ischemia, again, depending on your threshold, I think we can check mark. Now detecting the occlusion and stenosis, this is another step that we saw that the randomized controlled trials, they brought as a novelty compared to the previous ones, was the use of vascular imaging. And detection of occlusion can now be done with a contrast injection with half of the contrast of a regular CT. And this is an example from the group in Erlangen in Germany, comparing an MRI and a DynaCT with intravenous contrast. And you can see here that they demonstrated a pretty good correlation, and they could detect with 100% accuracy. And you can see here by the quality of the image, the presence of the proximal occlusions when compared to the pre-operative imaging. So all those studies have been only pilot. We need to do larger trials, but they are pretty encouraging, and also the imaging quality as well. Another study from a group in China, from Shanghai, they did a pilot study evaluating the cone beam CT in 17 patients and 21 exams, and they demonstrated that the performance for large vessel occlusion is excellent. But the technique is still limited when you are looking for small vessels or distal occlusions. So this is probably something to consider and to take in account. If you don't see a large vessel occlusion, probably then this patient will need an additional imaging, but you will have time to do this imaging and not sacrifice a patient that will require a treatment in a first moment. Then the next step is how to detect a tissue at risk. So those scans now can perform what we call dual axis studies. So they can do one rotation and immediately after can come back. So we can think on doing dynamic exams like perfusion imaging. This is the way that Philips is being proposing. We inject contrast, we see the bolus, and we do 2 6-second rotation. And this is the way that the DynaCT Siemens is being proposing. So they propose multiple rotations of 5 seconds over a 25-second period of time. And after a saline and contrast injection intravenously. And this study that it was a pilot study published last year in AGNR demonstrated a pretty good correlation between the different parameters that we usually observe in perfusion with the cone beam perfusion. And they developed CBV, MTT, and TTP-like of maps. And as you can see here, they reported, despite being only 2 cases, a pretty good correlation with that. So, but those cases, if you look in details, they were not cases for treatment selection, so we were not looking to the tissue at risk. We were looking already a lot for constituted lesions, but we have to give credit to the group that has been trying to implement this imaging and understand how we can read those maps with this dynamic imaging use cone beam CT. We can also use cone beam CT to evaluate the collaterals. This is a paper that is recently, again from Germany and Shanghai collaboration using a Siemens machine, using the CT for collateral evaluation. They also used to calculate the clot burden, and since they have the regular CTA and a delayed run, they can calculate more precisely the clot burden when you compare with angiogram. And also they evaluated the collateral using all scales, and despite we have no data regarding the amount of radiation, but we can have a dynamic CT and reconstruct in different ways, and they could at least on the anterior circulation cases, evaluate all the scores of collateral that have been used and published up to now. On the Philips machine, we have a similar protocol. This is an example of an imaging to evaluate the collateral. Is a work in progress from our lab. And the idea is also to use those two rotational images and to evaluate the collateral and build maps where we can actually calculate a potential collateral circulation. This is, hopefully, I would like to be able to present to you next year with some encouraging results of this research. So now, I think we kind of demonstrated that at least for acute imaging, we are there, almost. I think to detect and exclude blood, we have accurate and reliable imaging methods. Everything else, including the penumbral image, they are experimental, but they seem to be reliable and they require still a lot of validation, particularly now if we want to implement these treatments in acute setup. And again, I'm not saying that we have to diffuse these angio rooms everywhere. I think if we look from the case that I presented you before from Barry, I would like to see a collateral imaging on perfusion before accepting the patient, because I want to know if the patient will tolerate those 2 hours of transport time. But for a patient coming to our hospital, I'm not so sure if I would need all this imaging to decide on a treatment that has a clear large vessel occlusion and a reasonable parenchymal imaging. So one-stop shop concept may decrease inter-facility transfer times up to 6 minutes. It's immediately applicable in high-volume centers for fast workflow towards intervention. Prospective multi-center clinical studies on benefit, accuracy, and workflow impacts in the management of stroke are needed, and new developments will for sure improve the quality of the image that we have now. I have to share the credits of this talk with the stroke team and our research team, and thanks for your attention.